So, firstly, I'd like to say a big thank you to all of the Royal College of Podiatry and the Royal College of Physicians and Surgeons of Glasgow for this invitation to present this evening amongst such an illustrious group of presenters. Lovely talks by the two presenters previously. So my presentation, the kids are all right, sports injuries in children. This is going to be very much whistle-stop tour, looking at some common sports injuries in children as well as injury prevention. But I want you to think outside the box. This is not going to be a cookbook of sports injuries and what you do with them. If you think that, then switch off now, because kids basically aren't that simple. It really is as simple as that. So you may also find a little bit of repetition where my presentation and Dr. Hill's, because we come from quite similar background. So with the kids I see a lot of children. What's the first thing that we do when a child comes into the clinic with a problem? We talk to them. Okay, it sounds really obvious, but we talk to the patient to get a history of the problem. History. You cannot stress it enough about gaining that from the child to try and establish how the injury has occurred, which in fairness will more than likely guide you on how you can help this patient. And we've talked about talking, which I enjoy doing, but I've started off talking about language because it is so vital when we're talking to our patients. And I've used this image by a Norwegian physio called Lennart Banston, where he discusses nocebic language. Now, it was touched upon in one of the previous presentations. And for those of you who are unfamiliar with this phrase, nocebic language are phrases or terms that cause a negative effect with a person. So if you have a brief look at all of the words listed on the right of the slide, there are some absolute crackers in here. And we've all been in clinic and heard most of these phrases at one time or another by other clinicians and, God forbid, yourself. And the words we use with the children we see can have such a long-term damaging effect. Simple example, the other day, I had a parent bring a kid in, and the first thing the parent got the child to say was, "Show James your bad foot." So immediately you have to deal with unpacking the problem with this bad foot, even though it may not be an issue. Another classic is where a patient announces to you that they've got weak ankles, that old chestnut. So please be mindful of the words and language that you use when talking to your patients. When discussing language, it guides us beautifully onto this slide, which where I talk specifically about language, and the exact language that we use with our patients and their parents is so important. So I have a poll, and if you go up on your screen, basically the simple question is, can we prevent sports injuries? Now, I love a bit of audience participation, and I would be fascinated to see how the poll works. Okay, excellent. That had the exact desired effect that I wanted it to have, because I was so specific about the language that you use. Can you prevent sports injuries? Simple answer for me, I would suggest no. Now, that's immediately meant I've gone against 2/3 of the audience, and it's not unlike me to try and be a little bit controversial. But I know this is a very flippant comment, but all sports have an inherent risk of injury. Doesn't matter what sport you're doing, okay? Even if you're playing flipping tiddlywinks, you could get, well, you might not get injured, but hey ho. But this time of year, we've got Euro 2020 on, we've got the British Lions playing. These all prove that you can get injured playing sport. So this is where I come back to the language. We can't necessarily prevent injury because injury is so multifactorial. And even using things like functional movement screening, they have not always been the most reliable for predicting or preventing injury. So instead, our aim is to reduce the potential risk of injury. And I know this has been touched upon. If you think about it, if someone's trying to sell you something, they'll tell you what you want them to hear. So some of the examples listed here for potential risks are quite common sense. We all know the kids, anyone who's a parent, the kid that plays a billion sports and never seems to stop. Well, do you know what? Sometimes they have to stop. And repetition is very useful. So some of this has been covered by Dr. Hill already, but it's very pertinent. So rest is relative. If you think about it, in my pediatric population that I treat, for some kids, their rest could be lounging on the sofa, pretty much doing naff all. But for other kids I treat, that could be going from 5 to 4 sports a week. Both are actually all right, but there needs to be a return plan commensurate with the injury. Using proper technique is common sense, and wearing the appropriate gear. Easy example is a mouth guard. You wear a mouth guard incorrectly, you're going to get injured. Strengthening muscles, so proper conditioning, is more what is appropriate to the activity your child is undertaking. So looking at the specific sports that you're doing, and it all comes under this umbrella of conditioning. Because most of us couldn't just go and run a marathon, but with appropriate training, we could potentially. I know that's a big call. Improve flexibility, stretching. I'm going to come on to this in a moment. And obviously play safe. I know Katrine talked about it at the start about the safety of different types of football boots. Pain. Now, you could go to an entire weekend seminar in pain. Pain is fascinating because it's so subjective. Now, again, back to my pediatric population, if you apply this to a child, and especially a young child who comes to see you, they may have no previous reference points to what they are experiencing. So how a 5-year-old interprets pain and reports pain is very different to that of an 11-year-old. So you need to be mindful of this when you're questioning your patient. Talking, again, remember that the child is the patient, not the parent. Even though that parent might give you some useful insight, the child is the patient. Also, just a little tip from me, I'm 6 foot tall. Get down on your knees. If you're chatting to a 5-year-old, you do not want to be towering over them. Emotional stress, again, another one you could spend hours debating. This pressure to win, and it might not come from the child. The child may be doing a sport they don't even want to do, but they don't want to let their parents down because their parents think they're going to be the next Ronaldo. So almost vicariously living through their child. Variety of sports. Variety is the spice of life, they say. Well, that is completely true in sports. Diet, clearly obvious, well balanced, right types of food to fuel you through the sports you're going to be undertaking. And sleep was touched upon before. It's not just sleep, it's making sure you're getting enough good sleep, okay? Appropriate sleep, allowing you to recuperate and repair. I know there's, having worked with Olympians, they will take their own pillow to the athlete's village to guarantee or try and enable themselves to get a good sleep. Stretching, oh my word, stretching. I want you to have a real think about this slide because we have all given calf stretches, Achilles stretches, any other flipping stretches regularly. But why? So the question's here to just think about. When was the last time you prescribed a stretch for a child and why? Okay, so have a think about that. Did the child actually do the stretch? Okay, or did they do it and then have some sort of compliance issue? Okay, now I personally doubt it very much with the children. I compare it to, say, if you go to the dentist and they ask you to floss twice a day. First week, you're absolute legend. Second week, you're average Joe. By week 6, it's a long distant memory, apart from the patient when they come in on the day of the appointment because they've stretched themselves to whatever that night. And did the patient actually get any improvement or benefit from the stretches that they do? Now, I can't see any of you at the moment, but I know there'll be a few of you nodding at your computer. Actually, I probably can see some of you. And you might find it's a yes, but potentially it's actually nothing to do with what you prescribed, as you've already remarked that they don't do it anyway. So how can it be? So on to some injuries, because that's what we were here to talk about. And I'm going to look very swiftly in 3 areas. or 2.5. The first one are apophyseal injuries versus osteochondroses. And the only reason I've put it up like that is because when you Google these terms, they regularly lump them in together, and they shouldn't be. They're two different groups. So your apophyseal injuries, calcaneal apophysitis. If Kylie was watching Sever's disease, she'd hate me. So your calcaneum, Osgood-Schlatter's disease, tibial tuberosity, Sinding-Larsen-Johansson, the inferior pole of your patella. And your apophysitis are results from a tractional injury to the cartilage and bony attachment of tendons, kids and adolescents. And most often, it is an overuse injury. Potentially could be compounded by a growth spurt with tighter inflexible tendon use or an alteration in tendon regime. Now, most of my patients suffering with calcaneal apophysitis recently, they've had a change in their training program. You get a kid come in, he has just made it into the first team, training harder, more frequently with bigger kids, and that's why he's got an issue. But we'll talk about load management a little bit later on. But just completeness for the slide, osteochondrosis, so your Freiberg, so your second met head, Kohler's your navicular, and Perthes your femoral head. Now, the etiology they think is unknown, but there's several proposed or possible etiologies having been investigated, including genetics, hormonal imbalances, mechanical factors, repetitive trauma, and vascular abnormalities. And I make no apologies for the busy nature of this slide, which I'm very grateful for my good friend, Associate Professor Kylie Williams, as it's very important. Now, we know calcaneal apophysitis is one form of heel pain. Now, on this spidergram, there's about 45 different things it can be, and it's still not an exhaustive list. But we know today that we're focusing on the musculoskeletal area, okay? And there's a few things which aren't on here, but I would just very quickly, for completeness, just want to draw your attention to the bottom corner. You've got this child who's in with heel pain, and we know the reason, but there'll also be your malignancies, your osteosarcomas, Ewing sarcomas. Remember that they're out there, okay? But that again is a whole nother presentation on its own. So we're back to load management. So if we remove trauma, for example, a kid getting smashed in a massive tackle within his rugby match, this slide is so crucial, and I have to thank an awesome physio called Tom Goom for the images on this slide. So you must understand your training load versus your tissue's capacity to handle that load. And you can apply this theory to your apophyseal injuries that we've just discussed. So unfortunately, injured tissue's ability to handle load is usually reduced. And Scott Dye covers this very nicely with his idea of the envelope of function. So the athlete won't be able to return to exactly what they were doing before straight away, as they have this reduced capacity. And then your training load is dependent on your training volume. How much, your intensity, how hard, your frequency, how often, and your type, which was alluded to by Dr. Hill. And the problems occur when this training load increases far too quickly. Now, if we can identify an area, or which area is key for each individual patient, then we can maximize the load capacity locally in the injured tissue and in all relevant tissues around it through targeted strength and conditioning. A combined approach of modified training, appropriate strength and conditioning has the potential to reduce injury risk and redressing the balance between loading habits and tissue capacity. And if you look at Cook and Docking's work, they suggest that rehab needs to be progressed so that the load capacity of the tissues meets the needs of the patient. So we've whizzed through calcaneal apophysitis. First line, heel raises. Go and look at the work by Dr. Alicia James, the only woman I know who did a PhD based on a bet, so don't ever argue with her. And her PhD work showed that the evidence is there to support simple EVA heel raises being more effective than prefab orthoses at both 2 months and 12 months being equally effective. Second line, footwear. Now I'm going to talk about football boots very briefly. I'm not going to try and do it at the same level as Katrine did. But is there a way of incorporating a heel raise into their footwear, and especially with football boots? Strapping is a good one. You can do a heel lock strapping for that. Karen here clearly should not give up the day job. Now, I've put stretching and strengthening in fourth, but loads of the kids we see who have calcaneal apophysitis don't have calf tightness. So why are you giving them a stretch? Don't do it. Load management we've talked about, and finally the sixth one there is about enforced rest. And I've had to do this before with a couple of kids who turned up on crutches and they basically can't walk. Now, this young man, unless you've been living under a rock for the last few weeks, you'll know as probably the most recognizable footballer on the planet. It's Cristiano Ronaldo. And there's a very good reason why he's in here. And this pretty much chucks out everything I've just said, in that your child, it doesn't really matter how good a clinician you are, because your child is not going to want some rubbish boots that his dad used to have. He is going to want to have Ronaldo's boots. So you have to work with this. And these are Ronaldo's boots. They are the Nike Mercurial Superfly 8 Elite. And these are what he's currently wearing. Well, he's not, because he's not in the tournament anymore. But he was wearing in the tournament until very recently. So this is what your kids are going to want. And as was talked about, yeah, depends. The kids version is not as high quality as the adult version. And one just very swift slide just to demonstrate again what you have to deal with when treating kids and young athletes. These are the current stats on boot brands at Euro 2020. And if you look at the pie chart, over 50% are Nikes, then you've got a whole load of Adidas and or Puma. So unless you go in one of those three, kids aren't interested, basically, because all the heroes are wearing them. You've got Harry Kane, he wears Nike Phantom Elites. Mbappe, he's in Nike Mercurials as well. Sterling, he's in New Balance. But there is I talked about having incorporated a heel raise. Now, ASICS do make a boot called the Lethal Tiger, which incorporates a 10mm heel raise, which would be, I think, excellent for calcaneal apophysitis. One downside, it's only in Australia, so you can't get it over here. But if you've got friends over there, get them to send a job lot over. Now, anyone who knows me well enough knows I have a real passion for hypermobility, really do, because it seems to be everywhere. And there was a period of time with every other referral was telling me that a patient was hypermobile. So what is hypermobility? Well, it's an excessive range of motion in any given joint over and above what would be deemed a normal range of motion. And if you look up the work of Professor Rodney Graham or Dr. Alan Hakim, they are legends in the area. And it's really common in the general population. You get it in a few joints or widespread, more common in females, more common in Asian and Afro-Caribbean backgrounds, and it lessens with age. And it, for a lot of people, it has no medical consequence and commonly does not give rise to any symptoms. And some would say it's advantageous, but it can have a relationship with joint ligament injuries, sprains, strains, tears, joint subluxations, fatigue, and dislocations. And if you go and look at the work done by the physio associate professor Jane Simmons, she's done a lot of specialist work in hypermobile athletes and physical activity, and these hypermobile patients who have the benefits of the physical activity that they undertake. And I'm going to, in the interest of time, I'm going to whiz through this, but you have your improved mental health, coordination, balance, sleep, digestion. So if you've, and managing ability to manage pain. If you've got improved sleep, you're going to be able to deal with the pain better. And if your mental health is actually better because you've been getting better sleep, guess what? You might be able to manage your pain better. Increased energy levels, strengthening bones obviously is related to Wolff's law of bony adaptation, reduced risk of some cancer, and guess what? You live longer, or you will have a chance of living longer. But there are barriers as well with this group of patients. So some of the misconceptions about physical activity is the bodily movement which uses energy above their resting metabolism. It's fear of injury and pain, and it's very common with this group of patients. Now they need to understand that they need to understand their body and start with an activity which feels safe, and then it can build up slowly, one step at a time. Fatigue, so classic with these group of patients. They need to learn about pacing, okay? Think of their body as a battery pack, and you need time to recharge that battery pack. And also, if you've ever done any work on spoon theory, you start a day with a number of spoons, and you can align them accordingly. Not enough time, set achievable goals. Make sure you involve the family. Low motivation and being boring, well, make it fun. If it's boring, they're not going to do it. So change it up, mix it up. I don't know what to do. So with regards to things, discussions about avoiding high impact sports and activities, that doesn't mean they can't achieve it. They just need to build up to it slowly. Okay, take their time. And that's where with this slide, I've put fatigue in the center, but actually you could have many of the outer ring in the center. Again, they kind of link very closely. If you're getting no sleep, then clearly you're fatigued. And if you're fatigued, then you're going to be more stressed, so you're more anxious, and then less chance of dealing with pain, and you might not want to eat. dysautonomia, so things like inabilities to stand, dizziness, vertigo. There was a classic one about a chap with rheumatoid arthritis wearing a rheumatoid suit, but I will leave that for another day. But if you think about this in the context of the athlete, they have a lot more to deal with before they even start. So consequently, these barriers we've mentioned in the previous slide need to be acknowledged. And the final area I'm just going to dash right through, okay? It's ankle injuries, ankle sprains. These are super common, and I bet you've all done it at some point. Commonest ankle sprain, excessive inversion, plant affection of the rear foot, internal rotation of the lower leg, leading to increased strain of the lateral ligaments, resulting in injury, okay? And it's occurred 50% occurred during sport. Okay, I've done it twice. Did it once playing hockey, stood on a ball, went over. Second time, did it playing rugby, trying to sidestep, thought I was Dan Carter. Well, unless Dan Carter is fat Dan Carter, that's never going to work. So yeah, really high recurrence rate, 70% they reckon. And over 50% of people don't seek professional help because they've been told it's just a sprain. I went to a lecture years ago titled "It's Not Just a Sprain," and they couldn't have been more accurate. Rapido anatomy lesson, ATFL, CFL, clues are in the names of what they are on your lateral complex. Primarily, the ATFL will be affected first, then the CFL. Most likely, that's my alarm, primarily ATFL and then secondarily CFL. They think possibly more because the deltoid ligament is potentially stronger, but also combined with presentation of the foot to the floor in an inverted position. And also the work done by Brostrom. Brostrom does a tendon repair surgery, and he found that ruptures involving both ATFL and CFL occurred in 20% of cases, whereas CFL alone was actually incredibly rare. You can grade your ankle sprains in the kids, grade 1 to grade 3, grade 1 being the mildest, all things being well, just some physical therapy, and that will improve all the way up to grade 3, where potentially you might need surgery. But also be mindful that there could be other things going on, especially if you've done an ankle sprain. So be aware of something like the potential for Saltaris fractures with an ankle sprain, and also remember your Ottawa rules when regards to imaging of your ankles. And your interventions to finish. So RICE, evidence-based is ropey. I don't need to tell you that, you're all intelligent people. Braces, okay? Braces actually, they will not make you weaker unless you wear them forever, okay? But as part of a rehab program, they're very useful and they can be utilized fantastically. Andy Murray, he wears an Aircast A60, but a personal favorite of mine is one called a Swedo Lock ankle brace. It's a lace-up one, intermesh, very useful. Proprioceptum exercises, these are invaluable. Make sure you have good relationships with your physio teams. There's no reason why you can't do all of this. Wobble board work, air cushions, clock checks, so standing on one leg and counting out the numbers, and then progressing it. So always making it that bit harder, but remembering you can go backwards. And finally, graduated return to sport. And again, this needs to be slow and steady. You go back too fast, you will get injured again. We've seen already recurrence rate of up to 70%. So in summary, to ensure that the kids are all right, as the initial title said, history, vital. You can't get anywhere if you don't know what's happening. Effective load management, you can reduce the risks significantly. You just can't say to someone that you're going to prevent it. And make sure it's fun, okay? If you're doing these things, if what you're doing is boring, no one will do it, especially kids. Kids are clever and they'll catch you out, okay? So don't make it boring. And we've had a really crappy 18 months, okay? And you can't do it on your own. So make sure you've got your crew sorted, okay? This is my crew. They get me through every week. So thank you very much.
Thank you, James. Let me just pop my webcam on again. Thank you so much for that. Again, yet more so a real insight into the clinical aspect of how we apply the evidence to the populations we see, and obviously in this case, in children. And we're actually going to skip questions now because we are in danger of eating into people's evenings a bit far. But perhaps you might agree with me if I was to summarize some of what you said in that timing is incredibly important. All of these things, like when you apply stretching, when you apply a heel raise, really important to the ultimate success. And you sum that up.
Vital.
Don't wear a brace forever. Exactly.
Yeah, don't wear it forever. Seriously, don't.
Don't wear it forever. No, it'll be bad for you.